Stephen Rodriguez to our CME conference. Dr. Rodriguez will be discussing the medical and surgical management of knee osteoarthritis. He attended the University of Vermont College of Medicine and completed his surgical internship in surgery at Israel Hospital, and his orthopedics residency at the Harvard Combined Orthopedic Residency Program, and also completed a spine fellowship at Mass General. Dr. Rodriguez practices at Falmouth Orthopedic Center, and his focus is on total hip, knee, and shoulder replacement. Yeah. So thank you. Take it over.
Oh, thank you.
Thank you very much.
So this I know on your attendance form it says, your evaluation form says total knee replacement. This is actually going to be kind of geared towards surgical intervention, but it's also going to be a heavy dose is going to be really the medical aspect of arthritic knee. So that's why the talk is an arthritic knee versus total knee replacement. And certainly very informal. If you have questions along the way, just stop me, because I'm going to kind of roll through some of this. But along the way, if you have questions, just slow me down and we'll talk. All right. Not going, yeah.
Sorry. No idea.
Hold on. 1 second.
It's Wes in Yarmouth.
Be quiet, Wes.
Good, great. So let's just start off we'll just start off at the beginning. Current treatment for the arthritic knee, and obviously it's critical to understand the epidemiology, the history, the physical exam, radiographic findings, and then treatment. We're going to kind of go through all those scenarios in this talk, some of them a little quicker, some of them we're going to spend some time on. So the current treatment for arthritic knee, the demographics, male, gender, 55 to 64 years of age, about 1%. As you get a little older, it's 2%. And for female gender, it's less, but then at 65 to 74, it's about 6%. And the cost in this country for a total knee, this is data taken back about 3 years ago, but just total knee replacement, $3.5 billion. Let's just talk a little bit about arthritic history. So functional impairments become huge, right? Because as we know, we're going to be graded upon patient satisfaction and patient function. So PROs, patient-reported outcomes, and then patient-reported functional outcomes. That's patient's perception versus your perception, and there's a big difference between the physician's perception and the patient's perception in regards to function. So that's going to be big coming up in 2018, 2019. I want to ask about the length of symptoms, the age of the patient, the expectations of the patient. Huge to understand what the patient wants to do with their total knee and their expectations. Obviously, the comorbidities plays a huge role in preoperative assessment, and then patients' treatment options, because not all patients will need to go through surgery or require surgery. The 3 absolute must-ask questions for an arthritic knee. These are the 3 most important questions. Do you have knee stiffness in the morning when you first get out of bed? Is your knee stiff? Do you have startup pain? And startup pain, the classic example is if you went out to dinner or you went to a movie, you sat there for 2 hours, and then you had to get up and go. You can always tell the patient with an arthritic knee because they're the ones that they're reading the credits at the movie, right? The lights turn on and they're not moving. They're like, why aren't you moving? And then you see them the first couple of steps, you're limping out. So startup pain after sitting for a period of time. So morning stiffness, startup pain. And how do you go up and down stairs? You go up and down stairs one at a time. That's classic. So if you hit all 3, if all 3 questions are yes, they answer yes, you have greater than a 90% chance that they have an arthritic knee. So those are the 3 major questions they ask. Comorbidities, malnutrition, albumin less than 3.5. For some reason, do you find that this comes under the radar? This kind of sneaks under the radar all the time, right? Someone comes in from northern Maine, you're talking to them, and you think they're going to do fine, and then all of a sudden they have a wound problem, and you check their albumin, and it's low, right? It's kind of like the vitamin D, right? The low vitamin D, calcium. You think they're, they have a healthy diet, they're doing okay, and all of a sudden you check and they're low. Smoking history, alcoholism, previous surgery, multiple blood transfusions, comorbidity or morbid obesity, diabetes, and corticosteroids. We see a lot of diabetes, smoking, and some alcohol history. You can usually tease that out during the history, during the history. And corticosteroid use is very easy to diagnose. Physical exam, gross inspection, right? You're going to go right back to the base physical exam book. Gross inspection is key. So this patient, obviously, probably some vascular issues going on, varus deformity of the joint of the knees, you want to think about the spine exam, hip exam, vascular. With regards to the knee exam, obviously, inspection, varus valgus angulation. Varus knees do very, very well with surgery. Valgus knees, so knock knees, a little harder to do technically. To put in a correct total knee and a valgus knee, it's a little more challenging. 10% of joints are valgus, 90% are varus. Range of motion, flexion contractures, hyperextension. So the classic is the valgus knee, knock knee, hyperextension, pes planus. That's a very common scenario, those three findings. And that total joint is a tough total joint to put in. So when you send that patient to a surgeon, if the surgeon has limited experience, that's going to be a tough joint. Knock knee, hyperextension. Those are tough knees to correct surgically. Anterior, posterior, varus valgus instability. Classic would be a high school injury, ACL injury, 30 years later, arthritic knee. They're absent the ACL. They usually have a fair amount of instability. Joint line pain, patella tracking or grinding. It's important if you have varus knees, so you're bow-legged, you have medial joint line pain, and the question is, do they have a concomitant patellofemoral arthritis? Because if they don't have patellofemoral arthritis, they'd be a great candidate for a unicompartmental knee replacement versus a total knee replacement. The morbidity of a partial knee is so much lower than a total knee, and the functional recovery is huge. And we'll go over that in a few minutes. Obviously, a fusion and Baker's cyst, that's a product of most likely arthritis. So exam, history, inspection, range of motion, effusion, crepitus, stability. This is right out of Frank Netter. And so this is taken out of his book, published about 60 years ago, and it still holds true today. So you actually have to look at the patient, talk to the patient, and get your hands on the patient. Spine exam, classic. So people have arthritic hips, knees. They also, a lot of patients will have an arthritic spine. Be careful, don't get fooled with an L3 nerve root problem. L3 nerve root, the L3 nerve will radiate down towards the knee, medial side of the knee, anterior medial side of the knee, and it can fool you periodically. Especially if the exam doesn't quite match, the x-rays don't quite match their complaints. Be careful, it may be referred pain from the spine. L3 would be the culprit. And so at that point, you do an exam, reflex exam, strength testing, potentially some x-rays, MRI, figure out the claudication. Claudication is pretty easy to, claudication is more the periphery and the lower part of the legs. Can be higher towards the knees, but that usually is a little easier to tease out. But the L3 nerve root occasionally will burn you. Hip exam, classic would be groin pain and buttocks pain, lack of motion or loss of motion. But be careful, there's occasionally some patients will have that referred pain from their hip to their knee, and it usually is just above the patella. So it's about 2 to 3 inches above the patella. They have a lot of pain, and they point to their knee. And then you get the x-ray of the knee, there's mild arthritis of the knee, and it's really referred pain from their hip. And that's a classic. And so patients will come in with countless exams of their x-rays of their knee, an MRI of their knee. It doesn't look terribly bad, and it's really from their hip. So that's where you really have to tease out the question if you have groin pain or, better yet, range of motion. Vascular exam, less likely. It's a harder one to diagnose. Usually claudication is more peripheral. But occasionally you'll find someone with posterior popliteal fossa pain. Think of an aneurysm in that site. Occasionally you'll find that's rare. In my 16 years of practice, I think I found 2, so it's not. But they will cause a fair amount of pain posteriorly. And by the way, they're always, right, it's never clean, right? It's always, you have some arthritis there, but you're scratching your head because it doesn't quite match their symptoms. They have severe pain and mild arthritis, and you're trying to figure that out. You're trying to figure out what their pain generator is. Pain generators, you name it, right? Articular cartilage, meniscus, synovial inflammation, loose bodies in joint, osteophytes. Classic, you have peripheral osteophytes rubbing up on the popliteal tendon, IT band can cause pain. Joint distension from effusions cause pain, and then tendinoses. Radiographic exam, classic. Take a weight-bearing view. If the weight-bearing view doesn't match the patient's history and exam, take a tunnel view. A tunnel view is a flexed knee exam. Everybody does a tunnel view a little differently. You have to talk to your x-ray technicians. But it's usually around 15 to 20 degrees of flexion on a tunnel view, and I've seen them as high as 45. So if the patient has a history, an exam of arthrosis, but they still have maintained their joint space, take a tunnel view, and usually you'll find it's more of the arthritis is more on the posterior condyles, and as they bend, you'll see it be bone on bone. Recently, I was flying out to Denver for a conference, and there was this advertisement and a brochure about glucosamine chondroitin sulfate, and they had a patient before and after, right? They said, you know, here's before. They had bone on bone, and then they took this product, this glucosamine chondroitin sulfate. Of course, now they have joint space. That's weight bearing, non-weight bearing. Be careful, right? So, kind of dirty pool, smoking mirrors. So, anyways, marginal osteophytes you're looking for, joint space narrowing. This is a varus knee, medial side arthrosis, bone on bone. Marginal osteophytes, then a subchondral cyst. So a subchondral cyst right there. And that's really for the American Rheumatology Association. You need those 3 things: joint space narrowing, marginal osteophyte cyst, or sclerosis. And that would be by definition osteoarthritis. And remember, always 3 views. The views that most people, the one view most people do not take is the patellofemoral view, and that can be critical. So always a sunrise patellofemoral view. AP, lateral, patellofemoral view, and if you're going to take your best X-ray, would be a weight-bearing X-ray. So initial treatment for osteoarthritic knees, physical therapy, especially if someone comes in, they're a little debilitated and they have lack of motion. Physical therapy is probably the first place to start. Weight loss, what a problem. You know, it's getting us in all directions now. So weight loss is a big problem. Nutritional consults, maybe a formal exercise program. Activity modification usually can help some of the initial pain generators, and then supportive devices, a brace, a cane. Here's an advertisement for a brace. Right. Who's going to wear a brace, right? Unload a brace? Who's going to put that on every day? No one's going to wear that, right? And so they're still very popular, but as a treatment option. But I can't give an unloader brace away. No one wears unloader braces, right? Can you imagine? So I saw this after I said, I just have to take a picture of this. Can you imagine this? I mean, you know, here's this executive woman coming in with her, you know, ultra grip unloader brace, and no one's wearing that. Cane, walker, lateral heel wedges. Lateral heel wedges are really great if you have mild arthritis and they're active. And you can order lateral heel wedges from Hanger. That's on Brighton Avenue as a Hanger. So a lateral heel wedge, usually about an 1/8-inch lateral heel wedge. But if you really want to do it on the cheap, you go to Roy's Shoe Shop on Stevens Avenue, and that, has anybody been in Roy's Shoe Shop? Oh, yeah, yeah. I mean, it's like you go back and you're like, you know, Harry and Ozzy, you're going to come walking right out the door. You know? Like 50 years ago. He makes a great leather lateral heel wedge, and it's cheap, you know. It's like $5, $6 for the piece of leather, and he just puts it on his grinder, and he grinds it down and puts it in your shoe. And bracing, again, I'm not a big advocate for unloader braces. The compliance is less than 10%. People just don't wear unloader braces. Conservative treatment, NSAIDs, as you certainly know the pathway on NSAIDs. COX-2 inhibitors, we really only have one that we use now. It's very difficult to prescribe. It's a huge amount of paperwork to prescribe Celebrex now, so we do it on occasion, but it's limited. Acetaminophen, tramadol, and narcotics. Narcotics is really the bridge to get you from the office to the operating room. Sometimes patients just need that extra 2 or 3 weeks, but chronic narcotic use for osteoarthritic hip and knees, I think that's probably a mistake. We don't see it much in Portland, but I see it a lot from north of Augusta. You'll see, and down east, you'll see a fair amount of patients coming in with chronic use of narcotics for arthritic joints. But in Portland, I think we do a pretty good job limiting that. NSAIDs most commonly prescribed in timing. This article, I think, still holds true, 1985 Clinical Pharmacology. 8 p.m. is better than 8 a.m. for timing of NSAIDs. And ibuprofen versus acetaminophen, that's been going back and forth now. Currently, I think the NSAIDs are more effective than acetaminophen, although a few years ago it was just the opposite. And it depends which company wants to support the structure and publish it. But I think NSAIDs still hold a better role than acetaminophen.
And is the timing on that just because you're capturing the morning awakening where they're really stiff?
That's right. I think that gets rid of that component of stiffness. Yeah. Now, this data is a little old, but in 1996, $5 million. $500 million. I was trying to find recent data on complications in NSAIDs and current costs, and I found this is about the only thing I could find. But you see it all periodically. Someone coming in with a GI bleed on NSAIDs. I suspect if you talk to the gastroenterologist, you'll see it a lot. But I rarely hear about it. But $500 million. Hypertension I see a lot, and it's one of the things we do in the office. Once we start someone on an NSAID, when they come back for their follow-up, we check their pressure again, because frequently you'll see that they'll have a rise in pressure. And renal insufficiency, we miss it in the orthopedic office because we don't check the labs, but I'm sure you see it on their your annuals when they come in. They've been started on an NSAID, but we certainly don't check for it once we start the anti-inflammatory. Intra-articular steroids, this is really the workhorse for mild to moderate osteoarthritis. First patient visit, usually they haven't had any injections. We use 40 milligrams of methylprednisolone and 2 cc's of 1% lidocaine. That's 3 cc's total. We do a lateral approach to the knee. So a lot of studies shown how do you put it in? You know, do you do a medial approach, mid-parapatellar approach? Do you do a lateral approach? But most of the studies are showing that your success rate going from a superior lateral patellar approach is better. Although Michelle Labatz is now using ultrasound, so I think that takes it right out of the question whether you're in or out of the joint. 4 injections per year, and occasionally you'll have a flare-up. You'll inject 2 days later or a day later, you'll get a phone call, knee swollen. It's probably the preservative in the methylprednisolone that's causing that flare. Minimal complications. If you have too many injections, obviously, slows down cartilage catabolism. There's a big one, viscosupplementation. This has taken a real whirlwind over the last 2 or 3 years. A lot of products on the market. We use Synvisc, Euflexor, and Orthovisc. There's also Gel 1. That's another product. It's been very difficult now with insurance companies and that to get that pre-certified. There's been plenty of data out. I'll show you the data in a minute, but hyaluronic acid, and they think that it may have some anti-inflammatory effect. It may stimulate more HA out of the synoviocytes when it's injected. And we know that the hyaluronic acid concentration of osteoarthritic knees is reduced by half. So that's the theory behind it. It lubricates the knee, has an anti-inflammatory product effects, anabolic effect, analgesic effect. I'm not sure about that. Chondroprotective effect is unproven. So a lot of folks feel that maybe there's some ability for viscosupplementation to stimulate the chondrocytes to produce more cartilage. That's never been shown. Synvisc is 3 injections or single injection. Uflex is 3 injections. Sometimes you can have a transient 24-hour synovitis. Difficult to work up. Usually you have to drain the knee, add cortisone, and when we do that, we send that fluid off for gram stain culture and sensitivity because it mimics an infection, an acute infection. So it's really tough when they come in, and they're swollen and they're painful. And so we drain it, inject with cortisone, and then send the results off for a gram stain culture and sensitivity. And most of the time I've never found, knock on wood, I've never had a Synvisc reaction where I've drained, they have had a transient synovitis, and I've drained it and they've had an infection. So I think it's, again, the effects of the product that you're putting in. Cost is $750. Be careful today because just because it's pre-approved, pre-certified by the insurance company, if the patient hasn't reached their deductible and you inject that, and they don't pay or they walk out of the office, $750. So it's amazing how many patients we have that they don't pay their, they're not at the deductible and they just kind of let that one ride. And so it's become a problem. One of the ways around it is you can write the prescription for Synvisc and then give it to the patient, and they go to the pharmacy and they pick it up, and then they bring it back to your office. But we haven't been there yet. Again, many double-blinded studies show no decreased pain using the pain scales. And the American Academy of Orthopedic Surgeons position, this was John Tung. He's an orthopedic surgeon out in Washington, Seattle. And he was the president of the American Academy of Orthopedic Surgeons a few years ago. And he made it his point to either prove or disprove the validity of viscosupplementation. So in 2008, the Academy was inconclusive on whether it should be used or not. In 2013, when John Tung was president of the American Academy of Orthopedic Surgeons, he was a year before that, looked at it, and there was no convincing evidence that it was working. So he put together a clinical practice guideline out of the AAOS that it had low support, was not conclusive. And of course, that stirred up a lot of the drug companies were a little upset with that. But there was 3 high-quality studies and 11 moderate studies supporting minimal clinical importance of improvement. So we still use it. We still inject with Synvisc and Uflexa, but we're very cautious in regards to the pre-certification, the cost, and what we tell our patients. There's really no great data supporting it. And having said that, you'll talk to patients, and they think it's the best thing ever. So it's hard not to do it if the patient's coming in and stating that they've had great results. So we do it. Nutraceuticals, I think this is going to go by the wayside. I mean, ingesting a pill, having it degrade in your stomach, and then somehow making it to the arthritic joint. I mean, we're really grasping for straws here on this one. But chondroitin and glucosamine sulfate patients, you talk to patients, so they believe that it's effective. So We don't advocate for it. We do tell the patients that if they have good results, continue. If they do not have great results, if they have limited results, we tell them to stop it, do a rest for a while, a drug, a time where they're not on glucosamine chondroitin sulfate, a couple of months, and then see if it makes any difference. Indications, obviously, is osteoarthritis. Contraindications, rheumatoid gout, pregnant women and children. Somewhere between $30 and $75. The drug companies are getting kind of smart now because now they're attaching calcium and vitamin D to it. So now they're feeling the pressure a little bit, so now maybe they'll keep that product going if they put some calcium on it and vitamin D. Obviously, everything you can imagine with an ingested pill or side effects. The results have always been questionable. So right from the get-go, there's been no studies that support nutraceuticals, no randomized studies that support nutraceuticals. Surgical treatment. So everybody done eating? All right, very good. Here it is. So that's what I do. Surgical treatment, arthroscopy, osteotomy, unique compartments, total knee replacements. We're going to go through all of that here in a minute. This is our only lunchtime video, so I don't think we have another one. So that's total. That's a knee femoral component. There's a jig on the tibial side of things, and you can see on the condyles is really this yellow area projects fairly well, but this yellow area is really void of cartilage, and you can see some cysts. Arthroscopy, very limited results. So there's been a number of studies recently showing arthroscopy in the face of arthritic knees, even for meniscal pathology, meniscal tears, is not effective. So if you have a 65-year-old lady, man, they come in, they have an arthritic knee, they have a degenerative meniscal tear, and you do an arthroscopic debridement of that meniscus, they're no better, no worse. So if it's in the face of an arthritic knee. And that was shown recently in the JBJS, Journal of Bone and Joint Surgery, British edition, this year, about 4 months ago. And that was a large study. And that's been shown time and time again. There have been multiple studies, a great study is the 3-group study, a placebo group, washout group, and a debridement group, no improvement. All groups had some improvement within the first 6 months, and then afterwards, no improvement at all. And that was back in '96, and then the British Journal came out this year showing that, again, no value for an arthritic knee. Osteotomies, opening or closing wedge osteotomy. Basically, you take a wedge of bone out of the tibia, proximal tibia, and you realign it. So if someone is in varus, i.e. bow-legged, you take a wedge out of the lateral side, you close it, hence closing wedge osteotomy. And the plumb line from the center of the hip joint to the talus drops through the lateral side of the joint versus in a varus knee, an arthritic varus knee, if you drop that plumb line from the hip to the talus, it drops to the medial side of the joint. So if they have bone-on-bone changes on the medial side, the theory behind it is to get the plumb line to drop over the lateral side. So if you do a closing wedge osteotomy, you'll push the weight-bearing force to the lateral side on good cartilage. I did a fair amount of osteotomy work years ago. Some of my most happiest patients are women because you're putting someone in neutral alignment into wave valgus. So now their alignment, they may be comfortable, but their alignment is way off. And so when they stand, I don't even want to go through it. Anybody see that video? Anybody have children? They're watching Nene, the video? Anybody? Yeah. Am I the only one? I won't go there then. I won't go there. But anyways, stank leg, they have the dance, yeah, where the leg is way out to the side, like this valgus leg, You guys, come on, man, you got to get into this. You got to get into this, I should, you know what I'm talking about? Have you seen this? Well, you can demonstrate then. Oh, okay. All right. But anyways, right, the leg is way off to the side, so it, And then they look at it and say, you know, you didn't tell me this is, you know, well, I told you your leg's going to be a little off center, you know. And so anyways, it's a problem because it's a cosmesis issue now. You go from a, you know, arthritic issue to a cosmesis issue. Works pretty well for young, male, overweight manual laborers. That's the big one. So 30, 35-year-old manual labor, overweight male, that may be the best option for a varus arthritic knee. Good results, right? 5 years, 80 and 90% success rate, 5 years. Drops down a little bit after 8.5 years, though, 60% success rate. So it does work, it helps. This is the one that I really enjoy. I think the results are phenomenal. Surgical treatment for varus knee, so medial compartment arthritis, bone on bone medially, no arthritic changes laterally. You have to get the patellofemoral view on this to make sure they don't have bicompartmental osteoarthrosis, but if they have patellofemoral arthritis, then hands down they're better off with the total knee. But if their patella has no arthritis, the patellofemoral joint is free of any arthritis and is purely medial side arthritis, a partial, a unicompartmental knee arthroplasty. I'm not sure why this isn't projecting as well, but so here's the medial side component. So a unicompartmental knee arthroplasty. These patients are going out, leaving the hospital the same day, and they're doing phenomenal. And you can bring these patients back to high level of activity, and they do very, very well with their uni. And so anyways, it's an option. And a lot of us, including myself, feel that if you correct the alignment early, they do not develop patellofemoral arthritis down the road. So if they have medial compartment osteoarthritis and they don't have a patellofemoral arthritis yet, if you correct their alignment, put them back into neutral, they do not develop patellofemoral osteoarthritis. And I think that's going to hold true down the road. A lot of people are studying that, looking at that, changing the alignment early on, avoiding other areas of the joint becoming arthritic. And so if anybody has seen unis, patients with unis, they just love, it's a home run. They love it. Some contraindications, you know, mainly it's flexion contractures, ACL deficient knees, it's a relative contraindication, and you have to have osteoarthritis. You don't want to have SLE or rheumatoid arthritis because that's more of a ligamentous problem, and that's where unis fail. Unis are technically more difficult to do. It takes me longer to do a partial knee than a total knee, so so technically in the operating room it's much more demanding than a total knee. The total knee, you're really working off your jigs and really taking off the surfaces based off your jig. The uni, you're really basing it off alignment and with very limited jig work, so it's a little harder to do. Here's a workhorse, so this total knee replacement. This is a cemented total knee. You can see the cement mantle on the base of the tibial component, that hazy white area. The alignment's great, right? Neutral alignment. The femur's under the tibia. There's no varus valgus angulation of the tibial plate, and this knee should probably go 20 years. And so the polyethylene between the femur and the tibia is now cross-linked, so they do a bisulfide bond cross-linked polyethylene, which we didn't have years ago, but we now have it. And all studies have shown that 20 years is no wear or minimal wear at 20 years with cross-linked polyethylene. We don't have 20 years of clinical data on cross-linked polyethylene, bisulfide cross-linked polyethylene. We have about, in the knee, we have about 10 to 12 years. In the hip, we have about 15 years. These studies are being done at MIT, so on knee simulations. So we think that this is going to go at least 20 years. So depending on if you use cross-linked polyethylene. Obviously, the implant companies have their hands in it. So the cross-link is much more expensive than non-cross-link polyethylene. And when we start talking about bundled payments and cost structure, where does that fit in? So if you have an 80-year-old patient, do you want to put in a piece of cross-linked polyethylene that's very expensive? The answer to that is probably yes, because you want to do the right thing for the patient, but realistically, probably a standard piece of polyethylene would be as well, function as well. So some decisions you're making on site. So this is the Knee Society. I love this, right? Knee Society tells us, Total Knee Society. You can bowl and play croquet, golf, doubles tennis, ballroom dancing, stationary bike. What happened to road bike? I can't quite figure that one out. Walking. Thank God the Knee Society supports walking after a total knee. Yeah, this is right on their website, hiking and swimming. This is a great article. This came out recently. The Mayo Clinic showed, they looked at 218 patients. So what happened, this is kind of a retrospective study. They had a large section of patients that were doing high-impact sports activities after their total knee replacement. So they said, let's gather our high-impact sports. So they formed a questionnaire, and it had to be high-impact. So high-impact was powerlifting, baseball, basketball. I mean, just really activities that you would not think would support a total knee. They looked at total knee. On those 218 patients in that 7.5 years, they found no difference in wear compared to low-impact patients. So, that was cross-linked polyethylene, by the way. So maybe there's some value in cross-linked polyethylene for high-impact patients that do high-impact sports. So this study is ongoing. This is the first round of publication. This was published 2 years ago at the Academy meeting, and we'll see. Everybody's kind of interested on following these 218 patients. It's kind of like when you go to the Academy meeting, these patients are kind of turning into like the Framingham patients. Like what's happening? 218 patients. What are they doing now for activity? Prevalence of total knee replacement in this country, 1.52% among the population, 2010, highest amongst women. Age increases as you get older, so 10% at 80 years of age. In this country, 4.7 million total knees performed in 2010, 3 million women. And that was the recent data published from Medicare data published in 2015.
Any thoughts about why it's higher amongst women?
Well, so they looked at age and they took age out of it, so they age adjusted, and that's a big question, we're not sure. So there's a lot of theory that more women seek medical attention as they get older, and but that still wouldn't make the difference, right, of 3 million. So, not sure, right? So bone density is never shown to increase your risk of osteoarthritis. Increase your risk of fracture, but not osteoarthritis. So, surgical timing, right? Timing is everything. Comorbidities, range of motion, patient education. This is a knee that's severely, long-term osteoarthrosis, terrible valgus deformity of the knee. Really? I mean, that's not tough. The results on that is going to be very tough. So you want to obviously refer that patient prior to this deformity. Keep moving here. 3-month history of joint pain.
Sorry to interrupt you right in the middle of the sentence. Do you think the higher rates of chronic narcotic prescriptions north of in the northern part of the state have to do with access?
Yeah, I do. I think it has to do with access. So I think that's access on all fronts, specialists and also primaries, right? So timing, 3 months of joint pain, radiographic osteoarthrosis, and failed pharmaceuticals and support devices. Preoperative, let's just talk to preoperative evaluation of joint replacement, social and environmental factors. 5 years ago, we really talked about this. Now with 2019 approaching with merit incentive-based payments, anybody familiar with MIPS? Merit incentive payments. So I'll get to it in a second. But anyways, social environmental factors are huge in joint replacement. Who's with you? Who lives with you? What's your house? How's your house set up? Because we're having more and more difficulty getting patients from hospital to rehab, and a lot of rehabs, skilled nursing facilities are denying patients into their centers, which means now the patient has to go home, which now puts them at a higher risk of complications. Cardiac events, the big ones, right? Congestive heart failure, aortic stenosis, pulmonary hypertension. Aortic stenosis is probably, in every study you look at in orthopedics, the #1 risk factor for complications in total joint replacement. So bad prognosis with aortic stenosis. So when a patient has aortic stenosis, they might as well get their cardiology consult to put that risk, give the risk assessment, because they'll never make it through preoperative testing if they have a diagnosis of aortic stenosis without a recent cardiology note. And really tell us if it's mild, moderate, or high stenosis. And pulmonary hypertension, that's another one. That's really the result of the end-stage result of aortic stenosis. But nutritional evaluation we already talked about. This is sneaking up on us over and over again in the state of Maine. And so we want to keep an eye on nutritional evaluation, albumin levels. Renal function, liver function, we kind of always know that. That's in the background. We do a pretty good job with that. Mental status, obviously, a patient has to comprehend and understand the limitations and their expectations with their joint replacement, especially knee. Hip replacement, you can do a minimally invasive intralateral total hip. You can send them out the door. You don't have to have physical therapy. They can get walks to follow up, and they come back. They're doing great. Do that with the knee, and you own it. So total knees is a very different treatment. A lot of physical therapy, multiple phone calls, trying to get that patient back into function. We've done a superb job in this community, and I think we have to really give credit to Tom Claffey putting this together and pushing this a couple of years ago. Screening and decolonization for MRSA and MSSA, I think, has decreased our joint infection in both hospitals, Maine Med and Mercy. There's been tons of studies out there now showing that it's very effective. So you can see the numbers, right? CDC showed 28% MSSA, 19% MRSA, 16% negative, coag-negative staph for deep total joint infections. That was followed up by another study by Scram, and he looked at, is there a correlation between the infected knee and their nasal culture? 6 out of 7 showed identical staph species and molecular typing, so the answer to that was yes, is yes. Gorwitz in 2008 showed a very similar finding, 28% for MSSA and 15% for MRSA carriers. And the real concept is, you're trying to reduce your biomass. Mupirocin is what we use for MRSA, and bacitracin is what we use for MSSA. Chlorhexidine body wash, everybody's given a bottle of soap, 2 bottles of soap. They wash the night before and the day of. Studies show 2 washes, but some organizations want you to wash 4 times before your joint replacement. We do 2. I think 2 is going to be really effective. 94% effective at 1 week, 65% effective at 2 weeks. So when you have that patient that cancels and you reschedule them 3 weeks later, turn the wheel again, do it all over again. Cost ratio, $70,000 for an infected total joint. So if you have an infected total joint, doesn't matter if it's MSSA or MRSA, $70,000 average cost. The break-even point for screening and treatment would be $26,000. So that means that if you did a revision total hip for an infection, that cost for that revision total hip would have to be $26,000 to break even. So the difference is huge, right? Basically it's worth checking. It's worth doing all the studies, right? It's worth doing the nasal swab, the treatment. It's worth having a nurse run it. And if as a process, anybody involved with process measures at Intermed, how to get things processed right. It's huge, right? So you can imagine, right, what's it take to do this, right? So you need to get the supplies, you need to get the swabs, then you have to have someone to do it, and then you have to have someone to follow it, and then once you find it and follow it, you have to have someone contact the patient, you have to write the script, get the scripts to the patient starts in person, and there's a big teaching component to that, right? You imagine telling some of your patients, hey, you have to, swab your nose twice a day with this ointment, which you have to pick up. So it's a big deal, and I think both hospitals, Maine Med and Mercy, and their preoperative clinic have done a great job putting this together. This is data just 2 months ago. So this is huge. Weight changes, I love this, right? I'm going to get my total knee, and I'm going to lose my 120 pounds. It's going to be great. No, sorry. If you look at the recent studies, Cornell Medical College looked at almost 4,000 patients, total joint arthritis, that was hip and knee. 70% of patients lost no weight. Total knee patients were more likely to lose weight, and they were more likely to lose weight if they were obese to begin with. They define losing weight 5%. So if you had a 5% reduction in weight, well, honey, if you're 300 pounds, 5% is 15, unless I'm doing the math wrong. Really, that's not much, right? And so 70% lost no weight, 30% lost weight based on their definition of 5%. Really? Really? You're going to say 5% on someone who weighs 300 pounds, they lost 15 pounds after the total joint. So they got a positive check mark. Boom. They lost weight. They did total joint. Look, that's their definition was 5%. At the end of the day, they don't lose weight, right? People don't lose weight after their total joint replacement. And then here's the big thing. You're going to hear this over and over again. It's going to come at you in different ways. Merit-based incentive payment systems. This is going to really guide, regulate, adjust, manage our patients. So in 2015 to 2018, we're going to combine PQRS, value-based payment modifiers, and electronic health records. We're going to put it all into one. We're going to call it merit-based incentive payment system. Orthopedists are right on the radar, so this is a big federal government thing for the orthopedists in total joint, total hip replacements. We're going to roll all this in. We're going to have to do patient-reported outcomes, patient-reported functional outcomes. We're going to be based on results, and we're going to be compared to one another on a revenue-neutral basis, and we're going to be scored on 0 through 100%. So in any given year, starting 2019, you can have a plus or minus upside or downside of 4% based on your results, patient results, and patient satisfaction scores, and a plus or minus 9% in 2022. So it's going to ratchet up over the years. This is going to mandate change on how we risk stratify patients, and it's going to be a very big deal because we're going to have to be working very, very closely with patient's PCP, the patient, and the physician in order to figure this out. So that's it. You're welcome. Thank you. Any questions? For weight? Yeah, so I think that it's very, it changes your recovery a lot, especially in your environmental situation. So if you're overweight and your home is set up that you have multiple steps and stairs, or your employment is such that you do a lot of walking, I think your recovery, if you're overweight, is much longer. And so if you look at the workers' comp data, I know that workers' comp's a little flawed, but workers' comp, if you have an obese patient in workers' comp, they take a much longer time to get back to their employment. Well, there's some data that's showing BMIs over 40 have lower functional scores. So, and then A1C, I didn't put it up, but A1Cs are kind of, we don't use them that much. We have patients with A1Cs of 8 and 9, but it's really their sugars at the time of surgery. So So if you control their blood sugar at and about the time of surgery and postoperatively, they drop down.
And I know at MAMED, as part of the pre-op, they have people go into like an intensive diabetic treatment before they have any sort of surgery, and they're getting blood sugars lowered, or studies that are like optimizing people for not just certain.
I didn't talk about sleep apnea, but that's the other one that kind of puts you in or out of the mix of joint replacements. Where are you in your sleep apnea? That's become very popular lately. But you're welcome. Thank you.
You can keep those.